Good afternoon. Good afternoon, ladies and gentlemen, dear conference participants. A very warm welcome to all of you to this technical session on model for psychosocial support and management of trauma during humanitarian crisis. This session will be chaired by Ms. Saima Hossain, Goodwill Ambassador for Autism in the South Asia region and the International Focal Point of Advisory Group on Disability Inclusive Disaster Risk Management, Bangladesh. And we have quite a good number of panelists. Dr. Tarak Kesharam, Medical Officer, Non-Communicable Disease, WHO. Ms. Selma Sekli, WHO Mental Health Technical Office for Cox's Bazar. Najish Arman, Research and Capacity Building, Shuchana Foundation. Naila Ahmed, Deputy Secretary, Ministry of Disaster Management and Relief. And we have, as a guest speaker, Honorable Mr. MD Shah Kamal, Secretary of Ministry of Disaster Management and Relief. With all of your attention and participation, I would like to request our session chair to start the session. Thank you.
Hello. Assalamu alaikum, good afternoon. Thank you everyone for coming. We have a lot to talk about, a lot to discuss. I want to give a little bit of premise for, certainly the focus is on psychosocial support and particularly our experiences in the Rohingya camps. But I want to give a little bit of a background on how we actually got started in Bangladesh for psychosocial support. In 2015, the World Health Organization, WHO, had organized a workshop, two-day workshop for experts in Dhaka. And as it was certainly many the countries in the region shared their experiences, the challenges, and what really was highlighted is that psychosocial support needs really tiered activity, and there was a significant shortage of expertise even among professionals. And at the last day there was a discussion, small group discussions, and what that ultimately culminated is we began work on developing a curriculum on psychosocial support. And so from 2015 till now, we've had several groups that we've created our own module training program. We have done several trainings, and it was started with the support of the Ministry for Disaster Management, support from UNDP, funding from JICA, and with consultation support from WHO, looking at all of the curriculum. So since I'm wearing several hats today, I'm also going to be, unfortunately, we had hoped that our WHO advisor for mental health, Dr. Nazneen, would be here to present on what that workshop was. So I have been charged with that. And what we've decided to do is, given the wonderful level of expertise and experience over here that you will hear more about, is to give you a little bit of what we call psychosocial support, what models that are out there, and to understand that what we base this curriculum on is a comprehensive encapsulation of all of the information from that. It was fairly challenging to get this content together, and one of our biggest challenges was trying to get specialists on trauma to come to Bangladesh and help us develop the training module as well as do the training. So without further delay, let me start a little bit on that. And I would really like, at the end of it, to have more time and input And one of the goals of this event today is to get some itemized ideas on how we can move forward in implementing this support. Okay, so. Okay, so yes, so it's models of psychosocial support, some experience. Now, just to give a little summary as what resulted in the 2-day workshop and other consultation experience that WHO Syria has done, what the situation really is. Can you read it? Okay. Is it legible? Okay, it's all right. Apologize. Okay, so if anybody wants this information, I'll be happy to send it to you. So a short summary of what the situation is in the Southeast Asia region, what we've experienced. Of course, we have a lot of distress that ranges from mild to moderate, and a lot of neglect of severe mental health disorders. So, condition of individuals that are already suffering from mental health conditions, that's a challenge in and of itself. And the other aspect is how to prevent traumatic experiences from ending up to be a mental health condition. So both ends. And then, of course, the other added complication is those with mental health conditions, what is happening to them, what kind of support are we providing to them when they are going through a humanitarian crisis experience. So, they have found the ministries of health in the countries after a crisis situation do not give priority to mental health and psychosocial support. Regardless of any situation, mental health is completely neglected. We are very aware of that. It is not really part of the health program per se, although it very much resides in there. So that in and of itself is a big challenge. Administrators of health services within disaster-struck areas also do not tend to prioritize mental health and psychosocial support. So it is an afterthought and always has been. I think that is not just true for Syria, it's true for any country, and we're becoming aware that it needs to be a priority. So for effective community-level action, we urgently need to enhance the existing mental health services, because when you have a very poor mental health service program already, you do not have the right experts, you do not have a model of care or standard of care, and within a humanitarian crisis situation, after that, you are even more incapable of providing that support. So the other part, of course, along with not giving priority, I said there's limited capacity, and we've neglecting psychosocial support really impairs any efforts that you put on physical rehabilitation. So, and that affects persons with disability even more, because for their experiences are even more traumatic in addition to that, and it takes them longer and harder to recover, and it affects how they function later on. If we even focus on a conversation on disability is always about increasing functionality, so that their poor mental health, poor psychological well-being affects physical well-being. So the other learning point from WHO's experience has been that any psychosocial support has to be culturally sensitive and locally appropriate and developed for that community. So understanding what that local community, what the particular population needs is key. It's not universal, because what we believe, what our belief systems are, it has to be based from that, and that you have to be sensitive of it. So it also has to be community-based, and competency of trained workers, not just on what is universally believed about psychological support and mental health, but also competency in the local, doing it in the local language and being aware of the cultural nuances. Okay, a little bit of an update on what the situation is on member states. There are very few countries with standalone mental health policies and programs. India, Sri Lanka, Timor-Leste, Indonesia, Thailand, Myanmar, Nepal have some form of a plan. Member states where their policy plan is fully in line with human rights instruments are India, Indonesia, Timor-Leste, and Thailand. Member states that have standalone mental health law, India, Indonesia, Sri Lanka, Myanmar, and Thailand. And only 2 member states have updated their mental health law within the last 5 years, and that is Indonesia and Sri Lanka. And we're talking, this is just a comparison of 11 countries in the Sierra region. So even when you talk about mental health law, we still have our mental health law is from the early quite a few from the British era, I believe. The Lunacy Act is still active. So it's a huge problem. And in the last 5 years, there's been 10 years or so, a lot of progress has been made. What we know about mental health is completely different what we knew even 10 years ago. So here's a little very basic psychology. And, one of the things I want to point out from yesterday's guidelines, Valerie, for you, especially, why I sort of brought up one of the main issues and we're missing the crux of the problem. So this is called Maslow's basic hierarchy of needs, and it talks about what a person's needs and priorities are, what enhances well-being. Okay, so holistically well-being, and it affects every aspect, and it's particularly relevant for situations where somebody is going through a crisis situation, or there's any kind of humanitarian crisis, and there's a disaster, or anything that happens. So at the bottom is what you see in the highlighted and the darker in bold, the needs that are physiological needs. This is what every human being needs are. Okay, so physiological needs are first. We need to be able to breathe. We need to have food. We need to have water. We need to have shelter, clothing. We need to be able to see. So that need is our primary need. Okay, all humanitarian action plans and guidelines take care of that. Okay, we have gained some proficiency for that. We recognize that as an important need, and we have taken care of it. Everything else above that, we're just kind of thinking of. But look at it. Look at safety and security. So a sense of safety and security, some things, especially after we've had a recent crisis with the Rohingya situation, we are thinking of. So the next thing a person thinks of when your immediate physical needs are taken care of is your sense of well-being comes from social stability, your family, how are they doing, your property, where are you going to stay, what has happened to what you left behind, finding employment, livelihood, and your other health needs. Then friendship, love and belonging. So that's next here, friendship, intimacy, love and belonging. Again, caring for your community, those who are important to you. After that, at the tip, is self-esteem and sense of self-actualization. Now, one is certainly related to the others, but where does self-esteem come in, and how can you focus on that if you're not providing any kind of support for somebody to deal with what they have just experienced, the traumatic experience that they have had. So self-esteem, I'll kind of read it out because the typing is so bad. Confidence, achievement, respect for others, the need to be a unique individual. Self-actualization is about morality, creativity, being accepted, so you're experiencing a purpose in your life, finding meaning in your life. That's what the ultimate goal of any human being is. This is relevant for every single situation where ultimately you need to find meaning for yourself and a purpose for yourself. So So keeping that in mind, what is psychological trauma? It's an emotionally painful, shocking, stressful, and sometimes life-threatening experience. It may or may not involve physical injuries and can result from witnessing distressing events. One of the things I believe in Japan and South Korea and both those places, one of the things they've realized that traumatic experience can occur just by witnessing it. So how a disaster is reported, what is shared, even those who are not affected at all can also be traumatized. And that's, I think, media has a huge role to play in that, and that's those countries have actually had people with PTSD symptoms because of the way of experiencing certain disasters, both natural and man-made. Okay, so some common reactions. Sorry for the psychology course, but just I think it's important. I am a psychologist. It's hard to resist. So common reactions to any crisis or trauma: shock and disbelief, fear, guilt, grief, confusion, sense of shame, along with the loss, and anger. All of those are very, very common. Now, when we talk about experience of trauma and then how we differentiate that to post-traumatic stress disorder is any of these symptoms, so some of these symptoms, they last for more than a month, but I think depending on the experience, if it's longer than 6 months. So symptoms are intrusive memories of the event, you keep having recurring dreams, you keep seeing it again and again and reliving it. Avoidance of those situations, even if the reality does not exist anymore. This we have seen when, after the Rana Plaza incident happened, people were afraid to enter buildings, and many people lost their jobs. Even government workers were not able to work anymore in those sectors because they were too afraid to even enter buildings. Negative changes in thinking and mood, which can be mistaken for some other mood disorder, but it's actually a reflection of their traumatic experience. Changes in emotional reactions, so very reactive emotionally. It doesn't always mean that you're crying all the time. It could be that you're quick to get anger, but it isn't your normal level, and it disrupts your ability to work, your ability to learn in school. For example, in Nepal, after the earthquake, children could not go back to school even though schools were built. The children were too afraid to go back into a building. Okay, something even as simple as that affected them even to like a year later. So how to prepare for and prevent psychological trauma, and I hope this is certainly important things to take into consideration into the guideline. Certainly ensuring safety and crisis prevention, both physical safety and psychological safety, and preparedness. So comprehensive safety teams and plans. Like I said, we've done a really good job when it comes to all the physiological needs, but psychological we haven't. And crisis teams and plans already in place, everybody's roles well defined, and taking into account people with other special considerations such as mobility, any sensory challenges, which I mean by that, if they have visual impairments or hearing impairments, as well as if they have communication difficulties, in which, whether you can hear or not, but for our group, when you're developmental disorders and intellectual function, where they don't always understand what is being said. So having these teams that are going out in the field after a crisis situation, that they're aware there are people who will not be understanding everything that you say. And even if you're giving a warning, that same things have to be considered. Just because you're saying something, does the person understand what is being told to them, and are they being provided the assistance? So the next step that kind of comes in is evaluation of psychological trauma. This is just a little bit of a graphical representation. I don't want to take too much of time going over it, but I would like to point out that it cannot happen in one go. There are various stages. and various, certain variables, their risk factors. One of the things that keeps coming up is why is somebody, two people who've experienced the same thing, not end up having, say, post-traumatic stress disorder, or how are they coping better? People have different coping skills. There are people who are more resilient, and also there are people who have those who care for them, who support them, who help them through that. They have supportive, their coping strategies are good. They also have people close to them who help them cope. That reduces the risk factors. So not having family, so if you've lost more family, you are going to be at, you're at higher risk. So even as you're planning, and even if you're trying to reach large populations, so in the sense that what we recently experienced with all of these refugees coming in, you can select people who are at higher risk, so who have been more closely affected, have been exposed earlier. Their vulnerability is higher because of their other disabilities, or even if they have a pre-existing mental health condition. All of that are risk factors. So this, even as you're planning and you're trying to figure out how do you reach 700,000 people, you can take those into account. And try to reach them first, because they have fewer support. And I take you back to the Maslow's hierarchy of needs. What is the first thing they will need? What is the second thing? Do they have those same things? If they have it, then they have a little bit more resiliency. They have better coping strategies. Okay, so our curriculum was, like I said, was based on a lot of information, research-based information. We did look at WHO's intervention guides. We reviewed research from traumatology. The main curriculum that was used was a PREPARE curriculum. That's a guide developed by the American Psychological Association and the National Association of School Psychologists. It's a very structured guide. It tells you what you need to have, what you should do, how to be prepared. So the PREPARE is an acronym, but it also kind of implies how to be prepared. Okay, I do have slides on each one, so I'll go. And the National Organization for Victim Assistance, that's one of the oldest models that exist. And then you've got your psychological first aid. So one of the things I want you to understand, and I'll go a little bit over what the basic premise is, because each of those models comes from a different school of thought, and therefore it covers a certain content and is appropriate for a certain population. So, if you just take psychological first aid, it sounds like it's complete. It isn't, because it was made for a certain population and comes from a different, certain point of view. Okay, so just to talk about what PREPARE is, it's a conceptual framework. I was hoping you would be able to just read it, but okay. So because you can't, I will read it for you. So conceptual framework of prevent and prepare for psychological trauma, reaffirm physical health and perceptions of security and safety, evaluate psychological trauma risks, provide interventions and respond to psychological needs, and then examine the effectiveness of the crisis prevention and intervention. So those are the guiding lines for what needs to happen in order to reduce psychological trauma. That's where this curriculum suggests. It doesn't really specify exactly what to do, but how to be prepared for it. Now, National Organization for Victim Assistance, this is one of the training many of us school psychologists had to get on a regular basis because of all the school shooting experiences. And I had received this training very early on because my mentor had experienced a school shooting very early on in her career, and she was not prepared. So NOVA training was started from the point of view of victims. Okay, victims, I would prefer to use the word survivors, those who had survived domestic violence in particular. So it's very much based on individuals and families, and very vulnerable group, very, children and women and families. It's been there for nearly 30 years. It has very strong, education protocols, very stringent training curriculum. But it's all about how to communicate with the person who has just experienced a crisis situation and talk to them. So we have taken a lot of content directly from them with permission, so that we can actually teach those techniques. Some of it is just about, and I think one of our presenters will go over some of the techniques that we talk about in there, is how do you listen, how do you ask? Because you may want to know something, but how do you ask when you're trying to provide, not cause trauma again, is really, really important. Because if you just doing surveys and asking people, oh, did this happen to you? Did that happen to you? That can actually continue your traumatic experience. So now the NOVA's activities are guided by 4 aspects through national advocacy. So it was designed from point of view of survivors. It provides direct crisis service to victims. That's what the organization does itself. It serves as an educational resource to both those who provide assistance to survivors and for allied health professionals. And its main premise is promoting better communication among its members. All of us who have trained, we are sort of in a national registry, and we all volunteer and are called in at any time. That's another thing I think as people get trained on psychological support, that there is a national registry and we can call on people who are there locally, who are available and can help. The other thing is it is very intense trying to help somebody going through a crisis situation, so you have to also be careful that you don't burn them out. Okay, so psychological first aid was developed by the APA, the American Psychological Association. The whole premise for them is that it's a humane, supportive, and practical assistance for all human beings who have recently been exposed to a serious stressor. So it is also very applicable for somebody who's had a serious medical diagnosis, who's had a loss through some disease, or who's been in a car accident. So it is a very versatile tool. It is frequently used in emergency room hospitals, and many hospitals do provide that. It's a non-intrusive practical care and support program. It assesses needs and concerns. It helps address to get basic needs as well, because it's on a smaller scale, one-to-one. So we have still taken a lot of that content into consideration. It teaches about listening but not pressuring people to talk. So if you're not ready to talk, that's fine as well. Comforting people and helping them to feel calm. Helping people connect to information and services and social support, which I think is, providing that information is also really important. So, and then protecting people from further harm. How do you even, not get re-traumatized because it's something that's constantly playing on the news or people are talking about it. So also that's that additional suggestions that's in their protocol. So some of the things that psychological first aid is not, because this term is used so frequently, it's really important that you differentiate. We use the same terms, but they don't always mean the same thing. So it's not something only professionals can do. Okay? It is meant for everybody, professionals, non-professional, everyone. It isn't counseling. That's not what it is. It's not psychological debriefing either. There is no detailed discussion on the distressing event. It is not asking people to analyze what happened or putting events in order. It's not investigating it. And although psychological first aid involves being available to listen to people's stories, it is not pressuring people to tell their feelings or reactions to an event. Okay, those are really key things. So after the lesson in psychology, what are the 5 mission areas that we have to keep in mind? Prevention, protection, preventing and being prepared, protecting for both physical health and perception of security. Mitigation is to contain or reduce the effects of the disaster, which can be both the physiological needs as well as emotional needs. Response, so responding to the psychological needs. Recovery, effectiveness, and measuring the effectiveness of crisis prevention and intervention programs. So that's from very psychological mental health phase, just to be clear. That's what we consider crisis management phase. So when you've taken care of the bottom tier of the thing and taken care of all the physiological needs, these are the things support. This is taken from the psychological first aid, sort of like a pyramid. So if you think of how we want to provide the support, these are the main things to kind of keep in mind. The social considerations in the basic services and society. So advocacy for good humanitarian practice. So we have various models for that, and some better than others. And as we're developing guidelines, we'll have a better structure to that. But for the psychosocial and emotional response, we haven't. So certainly this needs to be, in consideration. So making it socially appropriate and keeping the focus as protecting the dignity of the person. So that's at the very first tier, ensuring that the dignity and self-respect of the person is maintained and that it is appropriate for their culture. Okay, so bringing your religious values, even that's what your organization represents, imposing it on a different group is not appropriate. So keeping those very basic things in mind. Then next level up is strengthening the community and increasing the family support. So activating social networks, supporting very child-friendly spaces. I mean, and it can be very challenging, particularly in our recent experience. We had so many children who were without their families and they were the only survivors. So they are, you immediately realize that they are the most high risk, as well as, so how would you provide this artificially so that that does not become the core issue and then lead to trauma? After you've done these at the community level, immediately and included as part and parcel of the first phase of any humanitarian action plan. Okay, this is the recommendation. It isn't something you do afterwards. It works best if you've done this at part and parcel. And if there's any way to incorporate this right away, I think we are all, as a human race, we all stand to benefit. So after that comes more focused psychosocial supports, where you are actually taking the more serious addressing the traumatic experience, the particular experience that that situation has caused. So, basic emotional responses, practical support, and then selecting individuals or the families that need more professional care. So at this point, kind of identifying who would need well-trained psychologists and counselors. The first 2 phases can be done by non-professionals, can be taken care, but you still have to train them, but it can be done within the community. You can have that part and parcel of any training program and provide it. And they then would be able to pick out those who need a bit more focused support. More psychological care. And of course, at the topmost is the clinical services. This is where we've had a little bit of a digression from how we've sort of provided services, but I hope with the two ministries, and Health Ministry and Disaster Ministry and WHO and other organizations will work together and come up with a plan that works together, because the World Health Organization and the Ministry of Health, just to give an example from our recent experience, and our institutes for mental health have focused on that part, clinical services, and because it is for people who have mental health conditions and who are already traumatized and need psychological support, and that is needed. But if we talk about being prepared and planning and to prevent trauma, we have to really strengthen the bottom two tier and certainly have that. I think the clinical service that really is very dependent on the existing mental health care and support program. So having well-trained professionals is and a system of care is extremely important. So without that, you won't be able to provide any of that support. So that's kind of pretty much it. So in conclusion, any neglect of psychosocial support can impair efforts towards a better physical health. Psychosocial support, in order for it to be effective, it has to have appropriate, culturally sensitive tools and mechanisms. You have to have a good understanding of post-traumatic stress disorder and how variations of it are expressed within society. And also really understand how people grieve and respond to trauma. What is culturally appropriate? So for example, in our country, crying out loud, and that's culturally appropriate, that's not extreme. In other cultures, that may be inappropriate behavior. So kind of understanding those expressions. Training the community level workers as much as possible, volunteers, training them both on the local language, using local language to provide that service. So collaborating with agencies and sectors. So not for any management. You can't do this because you will never have enough manpower. And you don't know at what point. So ideally, anybody that is working with that would have had some training in this so that they can immediately speak in the use the right language, use the right approach, as well as recognize if they need more professional help. So, some of the recommendations from our experiences, both in Bangladesh, as well as what we have done with the World Health Organization and the WHO Zero in our region, is we recognize that we need to have a collation of the tools and guidelines. So I was really excited about hearing the guidelines over there, and perhaps a bit more focus on mental health within that, and we can be incorporated. I know you want to keep it short and snazzy, but it needs to still be there. We can, like I said, it's not something that we can put off for later. It's very much about a part of what the whole human being is going to have to live with. Standardization of guidelines for psychosocial support is required. What we can call it psychosocial support, it's not always. Everything is needed. There are different parts needed. So kind of taking it together, standardizing it, and then disseminating it in an appropriate manner. And identifying mechanisms to improve the community's resilience and community's involvement. Because wherever sort of disaster happens, they are affected. And even if you have in situations like this where you have refugees, where they're going to be, that's also almost like a crisis situation, and there needs to be involvement in the community and support for them as well. So all of those aspects are important and necessary, and that's all I have for you today, so thank you. Yes? Do you have a question? Yes?
Thank you very much for an excellent presentation.
I can hear you.
Can you kindly come back to the pyramid?
This one?
Yes, exactly.
Yes.
If you look at the first two bases there, social consideration in basic security services and security, strengthening community and family supports. I just came from Jordan, where I visited some camps and I discussed with humanitarian operator. And there is a lot of CBR, community-based rehabilitation programs, going on both in urban centers as well as in the camps. And they do whatever is in the CBR matrix, but mostly they try to help people rebuilding their life in a situation in which they will have to settle in for some time. So my question is the community-based rehabilitation approach, which has been promoted by WHO and applied by a number of organizations, fitting into that? And do you see fitting also in what you just mentioned, building resilience of communities, displaced, migrants, refugees, into a humanitarian approach? Thank you.
Absolutely, excellent question. I'll bring you back to what I started off here. This is where I think CBR, when you look at the physiological needs, I think that plays a big role in that rehabilitation, finding employment. So the first two, first tier and the second tier are certainly relevant. When it comes to psychosocial, emotional well-being, that's what is not covered within that. So that's the only limitation. It is certainly necessary, it's not complete. So if we think of persons going through a crisis experience and what do they need, yes, certainly rehabilitation, physiotherapy, getting them employment, all of that are necessary. That is what's at the bottom, the physiological need, and there are good models. So that's where that would fit in, and some of that would lead to, so not just job training or ways to get employment, so being able to be employed, so the first two tier. But look at the rest of the pyramid, there are 3 levels that is completely left out. So it's good, it's not enough, and it's not enough for long-term mental health well-being.
I'm Dr. A.M. Zakir Hussain, and I worked for government for 29 years. I retired as Director of Primary Healthcare Disease Control, and disaster control was on my portfolio, and also I worked, as you know, in Southeast Asia Regional Office as Regional Advisor of Environmental Climate Change, and I had a fortune to meet you, ma'am, there several times. Now, it was a very useful, wonderful presentation, and congratulate you and thank you. But it was very heavy dose, as you have said, on psychology. And with my dumb intelligence, I cannot keep all this into my memory cell. So I wonder if there's any way to get this presentation, or you have a full patency right on it.
We will try to get the presentation to you. Let's maybe have a list of emails. And yeah, we'll try and what I will try to also do is add perhaps links and websites, so give us a few days. But just remember, a lot of this content is taken from those resources, so just as long as you remember to, as you share it, that it comes from that. Okay. So we have a lineup of presenters. I don't want to take away everybody's time. So with that, we'd like to invite Dr. Tara to talk about the WHO's guidelines.
Good afternoon. Thank you, Madam Chair, especially for your presentation. My respects to our chief guest and my fellow panelists and our esteemed colleagues here and participants. I'm Dr. Tara Kesaram. I lead the team on non-communicable diseases and mental health in the WHO country office here in Bangladesh. And today I'll be presenting to you on one of WHO's main initiatives for mental health, MHGAP. So a brief outline, I'll discuss the need for such an initiative, what is MHGAP and its contents, how we've recently used it in Bangladesh, in Cox's Bazar, and how it links to other tools which you've heard a bit about already. The global burden of mental disorders, neurological disorders, substance use disorders is immense. In 2015, it was clearly evident that almost 10% of the global burden of disease, that's years of life lost and years lived due to disability, was due to MNS conditions. And when you look specifically at the top 20 leading causes of years lost due to disability, you find that MNS conditions dominate that list, with depression leading the top causes there. And in Bangladesh, we also see this. Over 6 million people suffer depression in Bangladesh. Nearly 7 million people experience anxiety here. So the magnitude of the challenge ahead is unequivocal. But despite that huge global burden of mental disorders, sadly, the majority of those who need treatment for mental disorders don't have access to it. Furthermore, the resources for mental health do not match the burden of disease, and that is exactly the gap in the MHGAP program. So MHGAP is a global initiative to bridge that chasm between what is urgently needed and what is currently available for mental health. It has two main objectives. The first is to bring together stakeholders and increase our commitment to allocating financial and human resources to the care of those with mental disorders. Second, and what I'll be concentrating on today, is that it seeks to achieve higher coverage of key mental health service interventions, especially in lower and middle income countries. MHGAP aligns well with the Comprehensive Mental Health Action Plan, which called for change. Not only change in the attitudes and discrimination faced by those with mental disorders, but a change in the way services are delivered. So redirecting resources from the tertiary specialized mental health hospitals towards community-based care so that we can achieve integrated and responsive mental and social health care services in community-based settings. Of course, MHGAP and mental health are integral to achieving sustainable development and the Sustainable Development Goals. And that's not only Goal 3 on good health and well-being, which includes targets and indicators for substance abuse, alcohol use, suicide, but also within Goal 3, universal health coverage. We must improve access and the quality of mental health services in order to achieve universal health coverage. Mental health, of course, also relates to many other goals in this framework, such as those relating to inclusivity for education and employment, and those relating to equality. So MHGAP is concentrated on developing our mental health care systems, and it's premised on this concept here. For a comprehensive mental health care system, you need the full range of specialized psychiatric knowledge and skills, so that you are able to care for those with common mental disorders to the complex and more rare mental disorders. Within that, MHGAP focuses on a smaller subset of that knowledge and skills. But with that small subset, non-specialists in their healthcare settings can care for the majority of those they see presenting with mental, neurological, and substance use conditions. It has a couple of key components. One is this. These are evidence-based clinical guidelines and decision-making protocols for those common mental disorders, and MHGAP focuses on a number of those written there. Around this has been developed a competency-based training approach for non-specialists, so your physicians, your nurses, your paramedics, to assess and manage these disorders in general health care settings. And also focuses strongly on supervision, coaching, and mentoring. A one-off training is unlikely to be effective unless it is accompanied by further professional development and supervision to support those who have been trained. So I've just included here a screenshot of what is available online, some of those tools for implementing these clinical guidelines here. We have a whole training package for training of trainers and supervisors, as well as a package for training of the healthcare providers for all of the modules listed in MHGAP. It's very interactive learning. There are a series of videos that have been produced for MHGAP, and you can find those online. In our training, we also use role plays, case discussions, case presentations. And in the training, but also in the clinical setting for application, MHGAP is now available for your mobile on both Android and Apple. So now I'll just tell you a little bit about how we've implemented MHGAP here in Bangladesh, most recently in Cox's Bazar. So we had our first training in November 2017 in Cox's Bazar. We had a refresher training in 2018, and we had a supervision and coaching visit 1 month later. And this was organized by the Directorate General of Health Services with support from WHO and with some excellent resource persons from the National Institute of Mental Health and the National Institute of Neurosciences. And in our training, we had physicians, general physicians, psychologists, and counselors from both government facilities and non-governmental organizations working in Cox's Bazar. And a total of 31 participants were trained in the original training and the refresher training. The refresher training did include some very fresh faces as well, so for some it was 2 original trainings. What we did was we prioritized the key modules in MHGAP, but we also took modules from the MHGAP Humanitarian Intervention Guide, specifically acute stress and post-traumatic stress disorder, acknowledging what our participants were facing in the field and the experiences of the population there. And I've just included here a couple of statements about what we have found from the evaluation of this complete package. So in the refresher training, the majority of participants reported feeling confident to assess and manage persons with mental disorders, which was a great outcome. For a more objective verification, during our supervision and coaching visit, we were able to see 6 of our participants on site, and our facilitators were able to observe them doing a clinical consultation. And the participants excelled especially in the competencies of effective communication, history-taking, and pharmacological intervention, with more improvement possible in mental state examination and psychosocial education. The participants recommended that in the training there would be more case presentations and on-site visits, so more interaction, but also that there be regular supervision by experts or peer group supervision to help them continue their confidence and their professional development. What are the next steps? So the next steps are essentially adaptation and implementation, not only in Cox's Bazar, but also nationally. And for that, WHO is working with the National Institute of Mental Health, first on adapting this large intervention guide to Bangladesh to develop context-specific clinical protocols and culturally appropriate training materials and manuals. And this will give us a standardized approach, which is essential for quality assurance. We also need to think about how we implement this within the primary healthcare system, a part of Building Back Better, which my colleague Selma will further detail. And I've just listed there 4 key elements that we need to consider. Identification of local champions. Champions are critical at all levels, especially locally, and those who will take on the role of supervising so that we can make sure that this initiative is sustained. Of course, we do need to train the healthcare workforce, those non-specialists, at selected levels and identify how and where they will be able to see patients and refer as needed. We need to make sure that our information systems are equipped to collect data on indicators which will demonstrate to us how our program is doing, how we are implementing, and positive health outcomes. And we need to ensure that there is sustained access to both essential medicines and psychosocial services. So MHGAP links to a number of tools, some of which we've heard about already. One is Problem Management Plus, which is individual psychological help for those who need it, based on elements such as stress management or problem-based solving. Psychological First Aid, which you've heard about already. Does link, of course, to the MHGAP Humanitarian Intervention Guide, which is more simplified and context-specific for those intense crises. And to the IASC guidelines for mental health and psychosocial support, which we'll hear more about from my colleague. These are all available online, and we do have some display copies here, which you're welcome to see afterwards. more information is available online at the website. I do hope that's given you an overview of MHGAP in a nutshell and what we are trying to achieve here in Bangladesh and our next steps going forward. I'd be happy to hear from you by email and take questions whenever the time is.
We'll take questions later. Thank you, Dr. Tara. I'd like to invite Dr. Sama Sel. I don't want to put your name. Dr. Salma to give us an overview of your experience at Cox's Bazar.
No problem. Very good.
Good afternoon, Madam Chair, Mr. Secretary, fellow panelists, and esteemed guests. Today, I'd like to present a bit of the mental health and psychosocial support activities and efforts happening in Cox's Bazar. It's a very complex situation. It's not easy to summarize, but I will try. Both what's happening, interagency coordination, and what we are trying to do as WHO. So currently, we are trying to respond to one emergency that happened 9 months ago. And we are preparing for another one, which is the upcoming monsoon and cyclone season. Now I'm going to walk you through with what has been done so far, what we are planning for the upcoming season, and how could this help us with the improvement of mental health care system in Bangladesh. So WHO projections suggest that severe disorders in a 12-month onset from 2 to 3% increase to 3 to 4%. Mild and moderate mental health disorders increase from 10 to 15, 20%. And there is no estimation for normal distress and other psychological reactions, but they reach a very large percentage, which means we are looking to tens of thousands of people to have more and more mental health conditions. Ms. Saima already presented this pyramid in her presentation. So most of the agencies are working on this intervention pyramid by IAAC. We recently completed the data collection of MHPSS services available in Cox's Bazar, and we saw that 20 actors are providing mental health and psychosocial support services, and most of the services are at layer 2 and layer 3. So there is a MHPSS working group that was formed in Cox's Bazar in December 2017. It is currently chaired by ACF and co-chaired by BRAC. And the other actors are Ministry of Health, Ministry of Social Welfare, Ministry of Women and Children, MSF Spain, WHO, MSF Holland, BRAC, UNHCR, IOM, Handicap International, Medical Teams International, Danish Refugee Council, IFRC, Danish Red Cross, UNFPA, World Concern, Relief International, Mukti, GK, and Save the Children. As WHO, we are working closely with the government for integration of MHPSS into primary health care. Part of this, as my colleague Tara explained, we provide MHGAP trainings. In collaboration with DGHS, we facilitated the placement of a psychiatrist in Sadar District Hospital. We provide strategic and technical support to the MHPSS working group. Recently, we formed and leading an emergency preparedness and response task force along with UNHCR. We help with the information management, coordination, and mapping of the MHPSS services. And we help with the coordination of MHPSS capacity building activities. So what is important, especially during emergencies, is working with coordination with other sectors. Currently, MHPSS working group is under health sector, but is also with close cooperation with the protection sector. Under this, we have gender-based violence subsector as well as child protection. Also, we need to work closely to cover the basic needs of the people with food security and nutrition, shelter, and water and sanitation units as well. So in April 2018, We formed this emergency preparedness and response task force with UNHCR. Also, IOM, Danish Red Cross, ACF, and BRAC have been the active members of this task force, and we are integrating this work plan into MHPSS working group plan right now. It is based on the guidelines of Interagency Standing Committee. The purpose is to guide relevant humanitarian actors' MHPSS efforts for a well-coordinated response, reduce the psychological impact of monsoon and cyclone season on the community, ensure the delivery of essential MHPSS services during emergency, meet the MHPSS needs of the most vulnerable and severe population, and enhance the capacities and skills of different actors to provide a well-coordinated MHPSS response. What we have done so far, we conducted focus group discussions with the community members to understand from their side what are their concerns about the impact of the emergency they are going through and what they are expecting to happen in the upcoming emergency, and how we can help them with their psychosocial well-being, and what is their expectations from the humanitarian actors. We are having regular meetings and sharing updates with relevant agencies, sectors, and MHPSS working group members. We developed a mapping of MHPSS activities in Cox's Bazar. This is not finalized yet, but the data collection is complete. We developed and disseminated technical guidance note on persons with severe mental health conditions, and trained mobile medical teams and outreach teams working under different sectors on psychological first aid. Next steps, we are handing this over to the MHPSS working group chairs and the working group itself to incorporate this plan to 6-month action plan of the working group. There will be facilitation of MHPSS basics and guiding principles workshop for health sector's members in this plan. There will be advocacy and guidance notes for other sectors' activities on MHPSS. The communication and coordination with other sectors, especially with communication with communities, will continue closely. There will be dissemination of key messages. One of the plans is to develop interagency IEC materials for communities on self-care, preventing separation of family members and specific disaster preparedness activities, and to develop roster of focal points for MHPSS activities working in different organizations. So, sustainable mental health care after emergencies present actually a unique opportunity for the countries to improve their mental health infrastructure. These points here show lessons learned from 10 different countries that achieved to improve their mental health infrastructure. The countries are Kosovo, Somalia, Sri Lanka, Afghanistan, Burundi, Indonesia, Jordan, Timor-Leste, and Palestine. So how it was achieved? Mental health reform was supported through planning for long-term sustainability from the very outset of the emergency. The broad mental health needs of the emergency-affected population was addressed. The government's central role was respected. National professionals played a key role. Coordination across agencies was crucial. Mental health reform involved review and revision of national policies and plans. The mental health system was considered and strengthened as a whole. The health workers were reorganized and trained. Demonstration projects offered proof of concept and attracted further support and funds for mental health reform, and advocacy helped maintain momentum for change. One of the examples we could look at is Sri Lanka. Sri Lanka had very basic mental health services up until 2004. With the tsunami experience, they used the emergency mental health care and the international support to make a rapid progress in the development of mental health services. So the mental health services extended beyond the tsunami-affected areas And in this map, you see the yellow areas in the first one, 2004-2005, showing the basic mental health services. And by 2012, you see that out of 27 districts, 20 districts have comprehensive mental health services now. As WHO, we are planning to continue supporting the MHPSS working group in Cox's Bazar for a well-coordinated response, and continue to support Bangladesh government, including interministerial collaboration to establish long-term sustainable mental health care. Thank you.
Thank you, Ms. Sama. I'd like to now invite Ms. Nazir Sharman and Naila Ahmed to talk about their experience in the Cox's Bazar and discuss the psychosocial support program.
A very good afternoon and Assalamu alaikum to everyone present here today. My name is Nazir Sharman and I'm currently working in research and training development at Shuchana Foundation. So my presentation today will be on Bangladesh's experience of integrating psychosocial support into crisis preparedness and management. So just to get started off with some background, it's seen that most individuals who are experienced to traumatic events often experience after effects such as numbness or hyperemotionality, hypervigilance that resolve within the first month. But for approximately 10 to 20% of those individuals, the symptoms often persist and cause lasting and potentially debilitating dysfunction. Recent community studies show that trauma exposure is found to be higher in lower income countries compared with higher income. These findings indicate that a high burden of this trauma exposure in low income countries is because of the access to trained mental health professionals is found to be typically low. Certain factors affect both the incidence and severity of post-traumatic stress disorder, and this includes certain factors such as the type of trauma that is experienced, the severity of the trauma, the cultural context of the event, and of course the individual's perception and interpretation of the event itself. So it is vital that psychosocial needs are adequately addressed in the time frame following, immediately after a traumatic event, as well as in the days following. This lowers the possibilities of developing PTSD, anxiety, or depression after a crisis. So crisis responders for mental health do not offer therapy at disaster sites, but they do help people build upon their own internal strengths to begin the process of recovering from a disaster. So this is a very key point to remember, that although disasters are short-term events, and most crisis intervention strategies are focused on addressing the physiological needs of an individual, which is the bottom tier of Maslow's hierarchy of needs. Even though disasters are short-term, the effects from the psychological trauma are often found to last a lifetime. So I'm now going to provide you with an overview of the training program for crisis preparedness and management for mental health, which is the first victim assistance program of its type in Bangladesh. Our trainings were for a period of 6 days, and this was followed by field visits, which were conducted in the Rohingya camps, I'll speak a bit more about this later on, but my colleague Ms. Naila Ahmed will be going into further details about this. So our training started off last year in August. Our trainer was Ms. Joanne Byron, a licensed school psychologist and trainer from the USA. The training was done in collaboration with the Department of Disaster Management under the Ministry of Disaster Management and Relief, CDD, the Center for Disability and Development, and Shuchana Foundation. Following the first TOT, a refresher training was held. This enabled the participants of the first TOT to relearn the contents from the training and also to make a linkage between what they had learned in the classroom to their field experiences. A second and third TOT was also held, which had about 20 to 25 participants from a variety of different sectors. This included the Ministry of Disaster Management and Relief, the Ministry of Defense. We had participants from Fire and Civil Defense, psychologists, from the National Institute of Mental Health, as well as representatives from other NGOs and INGOs. So the training for Crisis Preparedness and Management Manual was adapted from the National Organization for Victim Assistance Community Crisis Response Team Training. This manual, with permission from NOVA, was modified for best practices due to cultural impact. The NOVA Manual Crisis Response Team Training has about 30 years of field-tested best practices as crisis management utility. The manual was then reviewed by a group of experts that included relevant stakeholders from NGOs, INGOs, educational institutions, and the government. So it is important to understand that by helping communities reduce these acute stress factors, we can help enhance their adaptive capacities, and they can eventually become stronger and better prepared with future threats of harm and injury. So this is just an overview of the manual itself. We started off with learning about the trauma response, the internal and external factors surrounding it. Then we went into addressing the different needs of different age populations. We were taught how to conduct one-on-one interventions, how to conduct a group intervention, and how to coordinate a crisis response team. So this diagram is a depiction of the different processes that take place following trauma and how crisis intervention can help change the overall narrative. So you can see here that without the crisis intervention phase, individuals often experience hyperarousal or withdrawal, which can lead to depression, anxiety, substance misuse, nightmares, or flashbacks. However, if it is possible to intervene at the right time and provide crisis intervention and post-trauma counseling, it is possible to change the overall experience of the individual and help reintegrate their trauma experience into a positive narrative that would ultimately also help them build up their resilience. This is just some of the key takeaways from the training. A lot of the techniques that we were taught were about active listening, the concepts of ventilation and validation, and how it's important to avoid assuming that disasters involve the same type and intensity of experience for all survivors. So once we arrived in Cox's Bazar, the first field attachment was in October of last year. We were there for about 6 days. What we had to do firstly was to go there, meet with the local administration. We attended the district coordination meeting to get an idea ourselves of the kinds of services that were being provided there. So it was time to put what we had learned in the classroom into practice, and even though we thought it'd be easy to apply those techniques once we arrived at the camps, we realized that the things we were taught in the manual about having a proper space to conduct our sessions where people would feel safe, there was no physical setup over there, so we had to improvise. So we conducted sessions in formal settings where we visited some of the women and children-friendly spaces, and a lot of our sessions were informal. We went door to door in the temporary shelters. We stood in line with them while they collected relief. We walked with them while they were going to collect relief, and just tried to apply some of our techniques in these settings as well. So Ms. Naila Ahmed, who will be the other speaker, will go into a little bit more detail about our field experiences. So I would just like to end by saying that our ultimate hope and goal is to be able to integrate psychosocial support into the national framework for disaster risk management in order to ensure that we have a resource pool of crisis responders that are available to adequately address mental health needs in the event of a crisis. Thank you.
Respected Chief Guest, Chair of the session, panel speakers, my dear friends and colleagues, Assalamu alaikum and very good evening to all. From this beautiful environment from Dhaka, I will take you a journey to Cox's Bazar, where the Rohingya people are sufferers and we take to act to help them as a caregivers. Ministry of Disaster Management and Relief believe on time to change. So, one of the targets from Dhaka Declaration was that we have formed a trainer pool for mental health support. So, a 5-day training was done. On the first training, we have 22 professionals from government agencies, including psychologists, social workers, and NGO workers. The training is performed by Joan Byron. Let us see what we have done in the classes. There we practiced some theoretical lessons. And now, the Rohingya situation arises on August and September in 2017. We have a plot there, the ministry organized with the help of UNDP, Shuchana Foundations, and other organizations, CDD, to a field attachment there with these professionals. There are we are divided into 6 groups. The first and second group, and third and fifth group, fourth and sixth group, in different time scale, we visited there for 1-week sessions. The main objective of the session this field attachment was provide a mental support to Rohingya influx coming in Cox's Bazar. At the same time, we have the objective to have a practical experience of crisis preparedness and management for mental health training through a field attachment. What the methodologies we followed. First of all, we have the meetings with the district commissioners, additional district officials, and other government officials. We visited the areas, individual trauma consultation sessions, as well as we have the group trauma consultation sessions. First of all, we organized the trip with, if you see this in the presentation, there are the areas where the Rohingya people are located, and with the demographic information, we selected which area we will visit. Then next comes the collecting information. We communicate with the different stakeholders, then visited the camps where the influx are entrance. We visited that side, the Anjuman Para of that area, as well as we take the help from the secondary sources of information. Let us see the pictures. The first picture is from the coordination session. In the district coordination session, we present there and observe the situation, as well as we go visited the fields. This is the picture from Balukhala camp of Ukhia. There you can see that the Rohingya children are taking lessons, educational lessons there. Whenever we go there, we feel that rest over the camps, we have to visit at the place of influx coming. You can see in the pictures that lots of people are waiting far behind the, near the hill area. They are waiting. And then after the BDS, one by one their entrance is done there. And we right after there want to talk with them to get their first impression or first trauma, if they have some trauma or like that. And then this is the situation there. People are coming with their belongings and like that. This is Shahpuri Ghat, entrance of the Teknaf. There you see the some people are waiting there for entrance. And this picture, the second picture is from secondary sources, a Reuters picture. But there you feel that how people are coming. The man is carrying a dead child. So how they are traumatized, how much they are in pain and grief. This is another picture from Marine Drive, Teknaf. Look at their face, how much they look back. Then the mental health services provided what we have done there. The group sessions, we have the male and female colleagues, male and female separately. The service of the session, the primary trauma counseling, then secondary trauma counseling. Formal sessions are done with the separate room to maintain their privacy, and the informal sessions were done by door to door. This is a day-to-day activities we have done there. Finally, the achievements, the objectives, the two objectives. One, the mental health providing services, we take to give a support to them at least 340 people, including 180 males and females 57, including 103 children. At the same time, the accurate and confidence build up around 5 trainees of my team on crisis preparedness and management for mental health. What we observed there, we observed death, destruction, displacement, disappearance, detention, disorders, poverty. On the basis of our theoretical experience, the anxiety, depressions, all these theoretical things we find during the consultation period. If you have a general observation, I can say that the people are suffering from flashback to their bad memories, sleep disturbance, nightmare, hypervigilance, low mood, palpitation, like that. What we finally conclude, people are traumatized. The Rohingya people are traumatized, but they have an excellent, impressive coping strategies and support. What the procedure was that we find a quiet space away from people to make them stable, then encourage them to talk, we help them to take a long breath or like that, and then reassure them what they will, yes, you are okay in the future, and provide the activity to redirect the energy. What are the challenges? Lots of challenges. We cannot practice all the things we are learning in the classes. Only we listener. We are the caregivers. We are the listeners. As well as we are not the professionals. We are non-professionals. So when we are giving care to them, we also feel traumatized because the situation was so grave, and these people are so in pain. So we the caregivers also suffer from this situation. These are the hurdles. These are the actual situation there. And people, the Majis are called that after Khalpar, the real situation occurred. That means that older people remains after the far away from there. Newer people are living far away from there. Forward planning, what from the field experience, what we get, sometimes it is difficult for the caregivers to listen non-judgmentally. For us, it is a really tough job because we are government officials, and then give reassurance and information what will be next for them, as well as encourage appropriate professional help. We have limitations. Obviously, we don't have a quiet place to give them properly, address them, but we tried. Secondly, we cannot screen the traumatized, categorized people, as well as the caregivers. We are very non-professionals. We have just a little bit training on them. So we are still in the learning phase. And this is the picture. We visited there. And finally, thank you for the active hearing.
Thank you, Ms. Naila and Ms. Nazish, for giving us an overview of the training and your experience in Cox's Bazar. I'd like to thank all the speakers for their presentations, and I know we've kind of run over time, but I'd really like for everyone in attendance to, ask any questions, but more than that, to give, we've shared our experiences, the challenges, a little bit more suggestions on how we can address it.
I witnessed something that I think is worth to share. JICA had a project, community project in Syria, and involving Syrian citizens helping each other at community level. And then what happened, but they were able to recover the same people involved in community work in Jordan where they left, as a refugee. Most of them had disabilities, and most of them were working as peer counselors in Syria. So JICA put them on the job of peer counseling in Jordan because they knew, as you said before, that the cultural link is the strongest element if you want to connect. So I was just sharing this information and just to cast in your own experience the Rohingya case, in which I have absolutely no experience. Second thing, a person who was an amputee told me that for him, psychological support was more important than the assistive devices that he got afterwards, because he got to get acquainted with his new life. And this was done before, during, and after. So I just shared this with you. Thank you very much.
Thank you for sharing that last part the most, really. But I just want to a little bit point out to one of the things that we had faced. Now, when we did the crisis intervention training, we didn't know that Rohingya situation was going to happen. So they weren't really trained for such a huge humanitarian crisis situation. But they still all volunteered and went and tried their best to provide this support. So they weren't well trained, but at least we were able to address it and we've learned from it. The other part of the biggest challenge is their language is completely different, and too many things get lost in using in translation. So You know, those are really major challenges over there. I think there was somebody in the back. Yeah.
Hello, hello, sorry. Hello, this is Bipin from UCEP, Nepal. I have like a pragmatic experience on psychological part after the devastating earthquake in 2015. There were like 15 districts affected by earthquake, but only we could walk to only 2 or 3 districts around Kathmandu because of our access. What I think is, like I want to say our experience, basically the main important part is to console the people after the earthquake. They are really fear, they can't sleep, and they don't want to even leave also. So basically what we do is a Hug and Heal campaign, and in the campaign that it was like to listen from the people. The important part was to get counseling support and healing support, and from visionary coaching and mechanic academia of Cyprus, it was like Akasa healing that we did to the people, and it did really help to the people. And other part, what UCEP Nepal did is like education in emergency project there. We created child-friendly space, and we provide like psychosocial support. And basically, what was the idea is that it is really difficult in this kind of situation to get access to every part. So we train a resource person, and afterward the resource person train the people in the community, and it really did work very nicely. And we like provide support to southern part of Lalitpur and Bhaktapur in Nepal. So I think it is really important to heal the people and make them able to live. And I, like in this session, I feel there was not anything like healing or something like that, or counseling part that is mentioned, and it is worthy to put in the policy and guideline that part, and it's really did work. Thank you.
Thank you for sharing your experience. What I would really like us all to do is provide suggestions, because we recognize that it's needed and the challenges are pretty similar, so I'd really appreciate if you could do that.
Hi, my name is Olga. I am the Mental Health Psychosocial Support Coordinator for IOM. And all these presentations just came some challenges in terms of addressing the phenomenon of what is going on, especially here in Bangladesh. I had previous experiences in other countries, as well in Colombia and South Sudan and in Africa. But basically what I think we need to keep in mind is that we need to start to address the suffering of the human beings as normal reactions to the abnormal situations. And the abnormality is not the response. The abnormality actually is the situation. So we need to start to avoid the medicalization of human suffering, and also trying to generalize the concept of trauma that I think is, in general terms, is a little bit narrow in terms of understanding the phenomenon, and give more complexity rather than cause-effect explanations that also is, in certain way, is a do-harm approach. So I think this is a challenge as well in the case of Bangladesh, how we can actually start to do some synergy with the resources and try to be focused as well, and try to make visible the positive responses of people, not just resilience, but also other responses like new developments that the people have had because of the crisis. So I think it's, in general terms, for me, it's a very important issue, how we address the human suffering, and we started to name in a different way. The general response is actually all the human beings that we have suffered or have faced a very critical moment. Is a normal response to be sad. It's a normal response to be anxious about the future. So in general terms, we need to start to address in a different way the responses, and how we are going to make more synergy with the positive responses of people in general, and try to avoid medicalization and the generalization as well of the concept of trauma. That's my main concern.
Thank you so much for your input. Interestingly enough, just to share a little anecdote over here, we started on the crisis response because especially we had Rohingya camps before, and from years ago, and having a close family member who works closely with actually with IOM and the Rohingya camps was very I was constantly kind of told like that we need support for them because they're people who have been traumatized, and that's where our training actually realized. But one of the points that you bring out is really important, that we should not over medicalize trauma. It is a natural response, and I think that's why part of the training, and so it is a very intense training, is to make that distinction. The idea is to reduce that, to validate the response somebody has from their experience, to provide all of the safety and security, but to ensure that it does not become a lasting trauma. That's the underlying premise of any kind of mental health. And, Dr. Tara, I mean, would you like to add anything to that? No. Yeah. So, but at one end is the immediate first response, where you're not. What we're trying to advocate over here is not just taking care of the physiological needs and the medical needs, but to recognize that emotional experience also needs to be supported. There's a certain way to do it. It's not something you want to do yearly. You want to do it if it's part of it immediately. You can do it without making it a medical kind of condition or a psychological condition. You can provide that support. You increase the chances of that person being able to deal with later on with their life without having being traumatized, let's say. So I think you had a question.
Yeah, well, I have a couple of comments and
some suggestions. I hope that will go.
Well, I don't know.
I promise it will be incorporated in the guide.
No, I won't give you a promise, but what I would say is that mental health is all along, I think, and it's going to be cross-cutting and as a separate topic. So for sure, there will be something as many details as we can. Okay. Couple of comments and suggestions. I think in my previous role, working really in humanitarian action, I think some strategies which I feel or I've seen working well were also by working with the community as themselves being trained in mental health, in psychosocial support. I think you also address your above layer of the pyramid when you do that, because people start feeling useful and start building up their own self-esteem. So I think that's something I haven't heard much along the presentation, and I think it's very important to bring that up. Then coming from a disability perspective online, I think one other thing which we heard from persons with disability in different contexts is that, well, either it's difficult to access because of communication issues, but there is also the understanding of the specific situation of a person with disability within a crisis context. And what we've done, and we've done that in different countries, is really looking at peer-to-peer working. I think really working in training organization of persons with disability to learn about providing psychosocial support, and themselves, again, being your community worker who goes and look for other person with disability and provide the counseling. There is a far better understanding of their specific condition. Okay, so for me that's one other point. And then my last is more question mark, but maybe also a suggestion. You've talked about the different training. It happened that I know a bit about the MHGAP, and I also know a bit about MHPSC. So of course, I don't know much about what you're doing in Bangladesh. But what is clearly missing to me there is that most of the people you train have not had any sensitization related to disability. So not even they don't know how to communicate to them, but their own attitudes towards disability may be quite negative. So I think including in those training, not necessarily youth session, but a small moment where you really address what is a disability, and better even if you can involve person with disability in that training to really explain what is disability, and trying to shift attitudes would be very, very good in terms of how you include disability in psychosocial and mental health programs. That's it.
Thank you. Both were excellent suggestions. I think that those points would really help in making this training a bit more robust. I just want to clarify one point of where these aren't deferring training. The one we took components of what was even guidelines within the image gap and image PSS. What those guidelines are for the mental health professionals, for a good, robust mental health program. What we've tried to take from that is how to translate some of that knowledge base into community-based, non-specialist. So it's like, because we recognize it has to be tiered approach, and how best to go about providing the tiered approach, and there really isn't a comprehensive mental health program at the community base. So that's what we're sort of trying to develop. So. Yes.
Thank you. On your last point, I definitely appreciate a need to focus more on disabilities. And just to note that MHGAP, one of its first modules is on essential care and practice, where it does address the attitudes and behaviors of our clinicians or healthcare workers towards those with disabilities, especially in light of the huge stigma and discrimination that is faced, and does focus on promoting respect and disability and dignity in accordance with the convention as well. Absolutely, I completely agree. Nothing about without.
I'm here with a proposal for the approval of the House. In every great job, there is a great person who has great activities for which the great job is successful, such as our country is liberated by the leadership of our father of the nation, Bangabandhu Sheikh Mujibur Rahman, for which he is designated as father of the nation. And for serving to the Rohingya people, as well as our bringing our position from bottomless baskets to space. Our Honorable Prime Minister is designated, honored as Mother of Humanity. Now, by observing all these disabilities activities for last 2 days, I now propose one proposal before you. If you agree, you must give your big hands. I will think that you have approved my proposal. I, Muhammad Didar Alam Chaudhary, do hereby propose the name of Saima Hussain as the mother of disability. If you agree, you must give big hand. As mother of disability, I want to designate her and name her. Thank you.
Hi, my name is Basundara. Thank you for the excellent panel. That's okay, thank you. So I actually have two things that I wanted to call your attention to. One was that while we see situations and crises as emergency and short term, there is a need to also look at them in the long term. We see the impacts of something like migration or a refugee crisis, not just in a few months, but you also see it for years to come. In a previous lifetime, I worked in Kashmir, and we actually worked with people who were a part of the war like 20, 30 years ago. That's a crisis in the making for ages. And you see the impacts of mental health and trauma manifesting themselves way after the actual crisis and event. So that is something that I wanted to get your thoughts on, is if any of these trainings actually have an eye for the long term, and how maybe patients themselves can learn to identify the signs and coping mechanisms to be able to respond to that in the long term. And the second thing I wanted to bring your attention to was that these kind of things are sensitive, not just for talking about in panels like these, but also for patients themselves in terms of privacy and anonymity. And if there were ways to ensure that for people, when you're serving them in camps, etc., when it's crowded and there's not that much space, is there a way to ensure that there is a way to, make sure they have the right to privacy when they're accessing services like this? Because any one of us in the room, if we were to go to a doctor for, mental health or psychosocial support services, would not want to be surrounded by everyone we know in our families and, you know, doctors and NGOs and people we don't know. So those were my 2 points. Thank you.
Dr. Tara, you want to take that one?
Absolutely, with a view to the long term, certainly MHGAP does link to psychosocial modules which focus on increasing individuals' capacity for self-care. Also, I appreciate the long-term vision that, especially as mental health conditions may develop sometime after, it really is important to build back a better mental health care system which can respond to those continuing needs as well. On the issues of privacy and dignity, I concur it's our duty to uphold and respect those rights within the context of a really difficult and challenging environment at the same time. And I'm sure others will probably be able to speak further on how they managed that and managed to balance both.
WHO is very good in doing one thing, developing training manuals. I was wondering if there can be one manual on how to provide psychosocial support to the victims in different settings based on prevalence of different psychosocial problems, how you respond in different settings, at camps, in health facilities, in offices, you know, like that, and then develop a manual on that and then train. I didn't hear one thing. When I was in Maldives for a short period, after 2004 tsunami, there was a very prevalent scenario of wetting of bed by children. So you also have to know how you really tackle, because it's not only one, for quite some time, for about 6 months they had these predicaments among children. So that can also be, that should also be in fact considered. Thank you very much.
Okay, I understand what you're saying. Certainly there's a difference in certain situations. I think what needs to happen is this combination of the guidelines for what to do in humanitarian crisis, and as Valerie has promised, where psychosocial support is intersected with those programs, will kind of take into consideration. And I think that's the idea, what we want to get the most comprehensive and looking at it holistically support. So we have time for one more question. Did you want to add? Oh, sure. I think that's it.
So there is already guidelines published by Interagency Standing Committee 2007, and most of the humanitarian agencies are making their programs based on these guidelines. For the technical part, coordination part, operational part, it's online, it's available in many, I don't think it's in Bangla yet, but I think ACF is doing it now, yeah? It's going to be even soon in Bangla.
Last question. I mean, if you have a real suggestion on how we can, enhance psychosocial support, I'd really appreciate it.
Yes, thank you very much. Very good presentation, Baral. Thank you. My name is Adam from UNHCR, actually based down in Cox's Bazar. Just to pull together a couple of elements that have been raised about the broad-based need, often low-intensity sort of need, the need to build the capacity and resilience in the communities. I just wanted to propose perhaps one complementary approach that could be looked into is, along with the work with MHGAP, along with the work of the sort of lay non-professional counseling services or crisis, if there would be an approach that looks at maybe even using some of those individuals, some of those professionals, non-professionals, but as an early stage intervention to go into the community and work with individuals, members, or groups within the community to actually design how they see what their needs are, what their response would be. It could be very effective also to overcoming a lot of the challenges like privacy or confidentiality or needs or cultural appropriateness. If you actually start sort of the mental health or psychosocial support process with working with the affected community in designing their own response, they'll be able to give a lot of impact and suggestions on what privacy means to them, or what is culturally appropriate, what services they're looking for, how they would normally support each other, and then how can mental health semi-professionals or professionals feed into and support that. So start at the design phase, and then use the tools and use the experience to sort of support a community-led process.
I needed you 2 years ago. That's exactly what I was saying. It took us 2 years to even get this. So in a way, it's really great that we all recognize the support. So, come, and I hope moving forward we'll be able to do that better. So last question.
Thank you very much for allowing me. I'm Mohammed Anisujuman. I'm working with GIZ, German Development Corporation. I'm actually not representing my organization here because my project is not directly working with any of the topic which is mentioned by education. I'm a psychologist. That's maybe the main reason. All these presentations were very, very thought-provoking. Some sort of guideline is also there. We understood that there are definitely policy gaps. There is not very widely mentioned about the mental health in our Health Policy Health Act. So we should be careful, or we may do some, what will I say, analysis, or do some amendment, or some sort of in the national health policy. Then lack of professionals is another concern for years, actually, since maybe 1950s. In Bangladesh, we have psychologists, but we don't have professional psychologists, since I am the evidence of that. There are many efforts from many organizations, UN organizations, UN agencies, and government and private sector in the responding to the emergency crisis in Cox's Bazar. But I found that from that presentation of Ms. Saima Hossain, I found that there is a huge need in the capacity building of the community level worker, and it was also mentioned by another discussant about the following the CBR model, and you can also think about that, since you have raised many models for psychological or psychosocial support. So these models can complement each other. My another suggestion is we can also think about capacity building, what Suchana Foundation has started with, along with CDD and many other organizations. I forgot everyone's name. This is a very, very good effort. But my concern is the coordination, cooperation with the UN agencies, with the IOM, with UNHCR, with WHO. Like that gap is like in a hierarchy level. You are providing very excellent service, very professional service, but the community services is also very, very demanding. Once the services or the professionals are there, or semi-professionals are there, then upper level service is less required. So my suggestion is to build the capacity of the community level workers for this mental health professional. Thank you very much. This is from my end.
Thank you for that completely unbiased suggestion, since all of those organizations are here. I'd welcome everybody to work together. With that, are there any other specific suggestions for us? We're very over time.
Just an information for Selma that we, ActionAid Bangladesh and Nari Consortium, together with Nasirullah Psychotherapy Unit of Dhaka University, we had translated psychosocial first aid one. So that would be helpful for that translation. That's all. Thank you.
So with all the comments and presentation, we kind of just summarize. I think there's a lot of work in silos, and we do, which keeps coming up. We need more intersectoral collaboration. We each specialize in certain things. We need to map out what we have that is locally applicable, particularly in this kind of, for our camps, the Rohingya situation is very complex. And it is a huge population of persons who speak a completely different language. So resources are even more limited there. And so what we really need to do is map out, work together, map out a plan of action and go step by step so that we can support people in this crisis situation in a way that they come out of it living more fulfilling lives. So thank you everyone, thank you presenters, and I'd like to ask our chief guest to give the final remarks. And I'd appreciate if you keep it short.
Respected Chair Ms. Saima Hussain, dear panelists, guests and dear fellow participants, good afternoon. The presentation of Saima Hussain and other panelists, it is very much encouraging to take proper decision in future. I only to comments about the Ms. Saima Hussain because we start journey in the year of 2015, but it is a very little time, but it is a very long queue. We hope that tomorrow will be more smooth and more speedy, and we take a proper decision. And we are conducting the session about models of psychological support and management of trauma during humanitarian crisis. Although you know that Bangladesh is a disaster-prone country, we face a lot of disaster in every year. So it is ongoing, but the psychological support is given by our health ministry, but there is a coordination because you know that we have a SOD, Standing Order on Disaster Management. As per SOD, we have a council. Council is headed by Honorable Prime Minister. And that council is sit minimum once in a year, but presently the Honorable Prime Minister to sit twice in a year. She give a more emphasis on the council meeting. And there is a highest body to give the all types of decision. So we are very grateful to our Honorable Prime Minister because he give the more emphasis on the every point of council decision. And you have to know that we have an advisory committee and there is an implementation. And the Ministry of Disaster Management Relief to coordinate all the things. In Rohingya issue, the influxes start in the 25th August 2017. Till today, there is a 5 cluster working. First, health and nutrition cluster. And that cluster is led by WHO and ACF. And there is a shelter and infrastructure led by UNHCR. Food and humanitarian assistance shelter is led by WFP. WASP cluster and security cluster and some infrastructure cluster led by IOM. So we are work together. From the government side, as a secretary to the Ministry of Disaster Management, I to coordinate the national level as well as I have an officer in the Cox's Bazar, TRRC. So he to coordinate in the Cox's Bazar, and every month I to visit in the twice. And all of agencies who IOM, UNHCR, SCF and other organizations, we sit together, we to take a contingency plan. So we are working. We can assure that day by day, we are to give the more emphasis on the mental health. So coming to forward to take care. Thank you all.
Can I ask the volunteers to come with the souvenirs? Thank you.
Excuse me, please, chotto recommendation only, not others. Please.
Sorry. Who's the official photographer?